My name is Samantha Tarok.
My name is Kamal Dillon.
I'm Anahit Yerdoglian. And I'm Rita Yerdoglian, and this is our poster presentation on the somatosensory system. The somatosensory system outlines the two anatomical pathways that are involved in the mechanosensory detection throughout the activation of peripheral nerve to the cortex. The posterior column medial lemniscus pathway is responsible for the proprioception, vibration, and fine touch. A projection is sent to the spinal cord through the dorsal root and enters the posterior horn. Looking at figure 1 at the different levels of the spinal cord from the lumbar up to the cervical, the dorsal horn is the top part of this H-shaped gray matter. Projections is then sent to the posterior horn to the brainstem via the dorsal posterior column, fasciculus gracilis, which carries information from the lower limbs, and fasciculus cuneatus carries information from the upper limbs. The posterior fibrous synapse with nucleus gracilis or nucleus cuneatus to the caudal medulla and the nuclei cross the midline and form the medial lemniscus. The third order fibers in the thalamus synapse ascend to the thalamus to synapse with the somatosensory cortex of the postcentral gyrus.
The second pathway is the anterolateral pathways, including the spinothalamic tract, that are responsible for pain, temperature, and crude touch. Beginning at the peripheral neurons, entering the spinal cord at the dorsal root, entering the posterior horn by the Lissauer's tract. Second or higher order fibers then cross at the anterior commissure to the contralateral side of the spinal cord, forming the spinothalamic pathway, continuing past the caudal medulla. In figure 2, this is the medulla as indicated by the inferior olivary nuclei with this squiggle-looking structures on both sides, onto the rostral pons in figure 3, indicated by these striations under the medial lemniscus pathway, and up to the rostral midbrain to the ventral posterolateral nucleus or VPL of the thalamus, which then project into the somatosensory cortex. Overall, the somatosensory cortex is spatially organized in a certain way, demonstrating neuron associations with the different parts of the body. These associations can then be mapped out somatotopically, known as the homunculus.
The trigeminal nerve is a sensory nerve of the face, which is activated in the trigeminal glandulin as it transports to the main sensory nuclei in the spinal cord nucleus. For touch and vibration, it transforms to the pons to the medial meniscus nuclei, which transforms to the cortex through the internal capsule. For touch and temp, it transmits from the caudal medulla via the spinothalamic tract to the ventral posterior nucleus. Comparative anatomy, we will start off with the sheep brain. There is no cluster response to the mechanical stimulation in the VL or the PNC like in other animates, which have more expanded thalamus and enlarged fibrases. The thalamus is going to respond to the stimulation of the oral or the peripheral surfaces, reflecting the behavioral aspects of the sheep. Direct stimulation of the dorsum column contralateral to the voltages was tested, and it invoked brain responses to the spinal cord.
Next animal we chose was a pig. In figure 7, we can see an image from a comparative anatomy study conducted on a group of 6 animals. The image is a 2:2 weighted MRI at the L1 through S1, specifically at the lumbosacral enlargements that contain the neural network and are involved with motor and sensory functions of the lower limbs. After completing the comparative anatomy of the pig lumbosacral region to all the other vertebrates shown in figure 7, the pig and the human are the most similar.
The first difference lies between the lumbar enlargements, with pigs having a little bit larger lumbar enlargement than humans. When looking at the total L1 to S1 region, pigs have a significantly larger lumbosacral region than humans, almost twice as long. Location-wise, pigs tend to have the lumbar sacral region lower lumbar area, whereas humans have it in the low thoracic to high lumbar region. Looking at the gray matter area at peak cord size, PCS, it's smaller in pigs. And just looking at the H-shaped structure that Rita mentioned earlier, it is already just seen by the eye that it's significantly smaller in pigs than in humans. Looking at the dorsal horn specifically at peak quart size. Humans' dorsal horns tend to extend more laterally from this midline.
The next specimen that we looked at was a mouse. In figure 8, we can see a sagittal cross-section of a mouse brain. In this image, we can see the different sections of the brain, which include the dorsal, ventral, and hypothalamic neuroepithelium of the thalamus, as well as the medial lemniscus and pyramidal tract. Figure 9, showing the somatosensory cortex of a human brain. It's comparing the human brain to a mouse brain. A clinical study was conducted by using gamma band oscillations. It was found when observing the band in humans there was an increase in the pain and perception, whereas when looking in mice we see that these bands increase more, with nociception of increased in alpha activity and resting gamma band. We also see in figure 9 that mouse brain is much smaller in comparison to that of a human brain, and the somatosensory cortex is smaller. We also see that the somatosensory cortex of a mouse brain is located in a different location than in the human brain. Our first case study consists of a 29-year-old woman who came to the emergency room due to having difficulty urinating. She was unable to urinate for up to 24 hours and had no tender points on the abdomen. She had myalgia and pain in her genitalia, and lymph nodes were enlarged. She also had a herpetic infection in the genitalia and was prescribed antiviral medication and antibiotics. Later on, she was discharged with Foley catheter and returned to the hospital after 12 hours with new symptoms of nausea and headache. She also mentioned that she had mild numbness on her buttocks and posterior thigh. When taken in a physical exam, she was noted for motor deficits, and it was diagnosed that there was a lesion in the central portion of the transverse myelitis inflammatory disease, which can be seen in the T2 weighted MRI showing multiple segments of the TM and cervical and thoracic vertebrae on the figure 10.
Our second case study is about a 25-year-old male who was admitted to the hospital after a clonic-tonic seizure. He developed epilepsy at 12 months. He is on epilepsy medication, but his seizures are not controlled. At 20 years old, he underwent a temporal lobectomy to stop his seizures. 2 years later, he did a right corpus callosomy, but his seizures are still pretty frequent. After regaining consciousness, he was noted to have paralysis of all 4 limbs, and they diagnosed him with Todd's paralysis. When they tested him again, his motor score was 4 on his lower limbs and a 0 on his upper limbs, and an MRI showed a lesion in the C1 spinal cord, and the diagnosis was central cord syndrome, as you can see in figure 11. You can see a C1 spinal cord lesion, and this is a T2 weighted MRI. After 1 month of rehabilitation, motor score went up to 30 in the upper limbs and 43 in the lower.
Case 3 is a 35-year-old right-handed female that presents to the clinic with gait instability associated with positive anti-RO labs, which are antibodies present with certain autoimmune disorders like lupus or rheumatoid arthritis. This patient was healthy up until 4 months prior until developing acute abdominal and back pain over the span of 4 weeks that has since been resolved and replaced with dysesthesia in the right arm and both lower extremities. 2 months prior, she began having right hand dexterity, impairment, sensory ataxia in both legs, and lost ability to independently ambulate. She saw a neurologist and was diagnosed with areflexia, limb ataxia on the right arm and both of the legs, proprioception deficits at the knees and right elbows. The dorsal column lesion in both the cervical and thoracic cord is affecting the cuneatus, fasciculus, and gracilis. Figure 12 is an axial T2 MRI indicating hyper-intense lesion in the dorsal column. Case 4 is a 49-year-old woman treated for 3 right kidney stones and discharged 24 hours after the operation, but readmitted 2 weeks later for ambulatory problems. Neurological exam findings were bilateral proprioceptive dysfunction, problems standing upright, ataxia, and hypoesthesia. Exam showed toe position and movements were normal. Reflexes were hypoactive in the upper extremities and hyperactive in in lower extremities, the Babinski sign not present. Spinal MRI reveals a lesion within the medulla at T10 to T11 level consistent with the cavernoma. T1 MRI of the spinal cord indicating an intramedullary lesion at T10 to T11 level with the arrow.
Case 5 is of a 38-year-old right-handed man who had a thalamic stroke 10 months ago, in which he noticed mild weakness of the left arm and the leg. However, but it was recovered within 30 minutes. Overall performed normally on all neurological, neurophysical exams. However, symptoms were affected of the central thalamus, which corresponded to the primate thalamus of the eye positions. The patient was relying on internal monitoring of the preceding static eye movements. The diagnosis was the MRI revealed a subsequent lesion of the right thalamus confined to the intralim and lateral nuclei. So if we look up to the image, we can see that labeled A and C are of the coronal view, which shows a expanded lesion on the thalamic nuclei. And if we look over on image B and D, that would be the portions drawn in orange.
Overall, the somatosensory system is a system with neural networks that involves conscious proprioception and exteroception from the peripheral nerves to the somatosensory cortex. Through the overview of the gross human anatomy and comparing it to the sheep, pig, and mice, we were able to effectively analyze differences in the somatosensory system of different vertebrates and gain a better understanding of the human somatosensory system through the different somatosensory related case studies. And that concludes our presentation.